Good morning. I'm, as it says, going to talk about the effectiveness of social prescriptions, which is kind of some of my jargon in terms of what are other things that are going on apart from medical prescriptions in the whole of this health and social care debate. But I wanted to talk about, being the chief executive of a charity, I wanted to talk about the role of the third sector in this integration of health and social care. So, for those of you who don't know, I ought to just tell you a bit about WRVS. Many of you will have heard of us, I'm sure. Many of you won't. We're an organisation that was started just before the Second World War. It's our 75th birthday next year. And we were a very empowering organisation when we started. It was created to give women a place and a contribution to the war effort. I'm not sure we're quite as glamorous as that these days, but I hope we are still quite as empowering. But as our 40,000 volunteers zoom around the towns and countryside and communities of England, Scotland and Wales, I think we're playing quite a strong part in knitting the communities together and delivering services that maybe wouldn't get delivered otherwise. We've gone through a lot of change, as all organisations do, but there's a big strand of continuity for us, which is in our early days we worked on wards in hospital, providing a level of care and support to patients outside the medical and nursing care, and we still do that today. And we've got 500 cafes and shops in hospitals across Great Britain, and we provide services and trolley services on the wards, and just work with and help and support patients both inside hospital but in their journeys to and from hospital. And we've focused a lot now on older people and how we can support and empower them in the communities. So let me just give you a bit of context about that. I mean, you will know all these numbers, I'm sure, but I always find this graph striking, which is the movement from 1901 in terms of people who were over 65 through to the 2001, 2011, and the projected movement through to 2081. And I kind of, whenever I see this chart, I sit here in 2011 and think about my 10-year-old daughter, Emily, in 2081, who's going to be sitting somewhere in that top cohort and thinking, hey, you knew all this stuff, Dad, and what did you do about it? How did you try and change things? So, you know, big changes, a big demographic context, but for me, this is about thinking about is this growth of older people, is it a tragedy or is it a triumph? Let's go back to 1901. Life expectancy at that point, if you were a female, was 49. If you were a male, 45. And as you saw on that graph, only 1.3 million of the population, about 5%, over 65. Come forward to 2008, life expectancy for a female has moved from 49 to 82, for a male from 45 to 77, and we're now talking 19% of the population over 65. Now, I don't know how that grabs you, but as a 52-year-old male, that definitely works for me, that kind of movement. And I think what's particularly striking, you go back to the start of the NHS in 1948, 48% of the population died before they were 65. 48% of the population. We're now talking about 18% and falling. So to me, that's a triumph of healthcare, of housing, of nutrition, of social care, of well-being. But the debate doesn't get framed like that a lot of time. Where does our thinking start about this stuff? The Chancellor last week said we'll also address the rising costs of an ageing population and the burden this places on future generations. Well, I understand what he's saying. All these old people, all this care, all these pensions, all this cost. But let me just kind of throw a different slant on that. Here's some work that we did last year about the burden, or otherwise, of older people in the population. And when we looked at the net benefits, the financial net benefits of those over 65 in the population, it's very clear that even when you take into account the costs of care, pensions, medical care and all the rest of it, the financial contribution of the over 65s is at this moment around £40 billion. That's twice what the British fashion industry contributes to the UK. And yet we don't kind of talk about those two things in the same way. And following the projection, by 2030 we'd be likely talking about £75 billion of net contribution to the economy. So I think it's worth just reframing the discussion a little bit. Let me just, I'm quite new to health and social care, so let me kind of just talk about how I feel things are. You'll all know this quote from Einstein: insanity is doing the same thing over and over again and expecting different results. And let me add a bit of Nietzsche in. Insanity in individuals is something rare, but in groups, parties, nations and epochs, it is the rule. So I come fresh, as I say, so we've just jumped about 1,000 slides. We are missing the other 15 slides in my presentation. Let's see if you can catch up, and if not, I'll talk through them. There's a diagram which the Audit Commission have used, which I think will be familiar to you all, that says, you know, there are rising demands on hospital places, therefore people are discharged earlier, not necessarily when they're well enough to... Okay, I'll talk through. Rising demand, people get discharged earlier and not necessarily supported, having been discharged, therefore end up in very expensive expensive care homes, and therefore end up being readmitted, money goes down, and so on, and the squeeze goes round and round and round. And I'd like to talk about what might be the solution to that, or one of the solutions to that, and how might charities participate in that. We're doing some work in a hospital in Sheffield on one of the wards, the many wards which have older people in them, and supporting the nursing staff, the medical staff, and the other hospital staff around nutrition, around hydration, about just structure on the wards to make sure people have a decent quality of stay in there. And I was just terribly struck when the director of nursing was saying to me, you know, people who come into this hospital having broken their hip, older people, a year on from that event, a third of them are back in their homes where they broke their hip, a third of them are in care homes, and a third of them are dead. Now that's, you know, you'll probably know this stuff, but that really, really shocked me. And in a lot of senses, I'm sure that is about care and structure and support for people when they're discharged from hospital, and how we can discharge people back to their own homes and their own communities. There's lots of stuff in the press at the moment about, you know, councils only think about dom care in minutes. It's only 15 minutes. But the answer can't be it's only 17 minutes, or it's 21 minutes, or it's 23 minutes. We have to think differently about how we can support people in their homes and their communities outside of well-qualified but expensive social care workers, domestic care assistants, whatever it might be. And I don't think we necessarily have to, and you were saying this a little bit earlier, I don't think we have to sit in a conflicted position about this. Sometimes it's about saying there are two systems that are coming together. There are two funding streams that we're thinking about integrating. There's patient experience, but there's medical outcomes. How do we find a bit of glue that brings those two things together? And I do think one of the great things about charities is because we're flexible, because we work with volunteers, because we're kind of less systematized, then we're flexible and we kind of provide some of that glue that goes on. I wanted to talk about a business case about why volunteering and charities can support this stuff. We've been working in East Devon with a GP called Anne Hayden, and she secured a £40,000 grant to think about how befriending and social contact would actually help the outcomes of her patients and actually deliver benefits to health and social care in her area. Now, there's a growing amount of research that says people who have stronger social connections in their community have a 50% improved chance of longer life. That's a comparable, as you will know, to other factors around morbidity, which might be obesity, which might be smoking, might be alcohol abuse. These are really strong numbers in terms of social connection. So Anne and us have worked together in East Devon with some of her patients to see what we could do. She got a £40,000 grant to support 400 patients, so £100 a patient. And what she's reported back after a year of this trial is that if you just take 6 patients who had the highest impact in cost terms to the NHS system in her area. She has saved, a year on from that trial, just around 80-something thousand pounds, £82,000. So in the year leading up to the trial, those 6 patients had cost the NHS through primary care, secondary care, appointments, scans, whatever it might be, £87,000. A year on, it's less than £5,000. That's only from 6 people. And of course, there are savings that accrue with the others. But what strikes me about that, let me just go forward and there we are, East Devon GPs. I think these are really important numbers, and whenever I show these, people who know better than I do say, ah yes, but regression to the mean and all of that stuff. But it seems to me that those kind of savings, and more importantly, those kind of changes to people's quality of life, are actually really, really important. There's a lovely quote from the daughter of one of these ladies who had lost her husband 2 years before this trial started, and those of you involved with primary care will recognise this, was repeatedly coming to the doctor's surgery, phoning the doctor's surgery, other people being referred for medical problems that weren't necessarily explainable. And the daughter of this lady said, I can't believe the difference in mum a year on from that. One of the 6 people who was creating a huge cost to the system through alcohol abuse is now managing that condition and is now volunteering with us to help other people in that. So, we've got a new volunteer. The system has saved a lot of cost. Why wouldn't you think about how we can integrate charities in the whole system? And if that doesn't work for you, the other thing that we're thinking about in terms of impact and outcomes is using SROI. And you'll know Cabinet Office supported as a tool of trying to create a sense of where's the value being generated, how can we express that in monetary terms. And our community hub in Hanley, one of many that we've got across the country, we've invested in a year about £280,000 in that hub, supporting people through transport schemes, lunches, meals on wheels, befriending services, whatever, a combination of things. But Frontier Economics, having looked at what we've done there, have said there's a social return on that investment of £600,000. And I think that's a pretty strong case myself. So let me just give you a small plug for WRVS, because I do think, like many other charities, we do important things. And services are being cut, a living, breathing demonstration of how investing a little money in community-based services can help transform people's lives, as well as generating very significant savings for cash-strapped public institutions. But you don't have to take my word for it. I just want to show you a little video which I think kind of expresses quite well the social benefits, the social prescription, and how that feels to our volunteers and both to older people that we work with. I'm hoping you've got the video.
Well, I married in 1945 to a RAF boy. We ran the pub for 7 years. We had 3 children, 2 girls and a boy, but the first girl died at birth. I've got 6 grandchildren. If I see them 3 times a year, I'm lucky. I've always worked, and I've never asked anybody to do anything for me. And now my life is absolutely reversed now, from being so active, doing everything myself, running around like a mad fool. Now I just got to sit here and think, is my head going to bash today, or is this going to burst? And then you go to do something naturally with your hands and it's on the floor.
Not far away lives single mum Jo Leung. She works long hours as a stock taker to provide a home for her daughter Jade. Until Jade was born, Jo was the main carer for her grandmother, who died soon after.
She lived on her own, she had her own house. She wouldn't come and live with us, but she got very, very lonely. And even though she was only 5 minutes away, and I used to pop in there half a dozen times a day, she'd still sit there looking at the window and that, waiting for someone to come and visit. And I thought it was really sad. And I thought there's going to be an awful lot of people in her same situation who weren't lucky enough to have good neighbours like she did. And then I saw a leaflet come through the door for WRVS.
Jo signed up as a volunteer for the WRVS Good Neighbours service. That was 2 years ago.
Hello?
Hi, Mary, it's me.
Okay, I'll open the door.
Ooh, are you okay?
Yeah. How are you?
I'm fine.
So where have you been working this week?
I've got a new job in place of the main one.
You won't have time to come around here.
I will, of course I'll have time. I like coming round here. This is my chair. You said yesterday you wanted some stuff in the shop.
Yeah.
Come on then, watch your step. She's very independent. I think her brain is still going 10 to the dozen, but the body's not quite allowing her to do what she thinks she can still do, what she used to do all her life. I mean, if she does want to go anywhere, and I'm quite happy to take her out, take her to the doctors, take her shopping and that. You all right?
Yes.
Okay. Do you want a basket and bananas? You got marmalade? Go on, I got it.
Jo is one of nearly 50 volunteers working for WRVS Good Neighbours in Newport.
Thank you, love.
£9.83.
I think she knows more about my past than my own children. When you've been, I feel better for having talked to somebody. Because as I say, they all says when I start talking, I don't know when to stop.
Where'd they get that from?
I don't know.
No,
I always thought I was quiet, but...
You are quiet, just like me.
Life began to change for Mari when her husband died in 1997. By then her children had married and had moved away.
I did go very low at one time, and the doctor said to me it's because there's nobody popping in and out. You know, you just sat here and you're not used to it. But now Jo's here, and I know she's on the end of the phone if ever I want anything. I couldn't be without her. I don't know what I'd do without her.
Fortunately for Mari, when Jo has to go away on business, daughter Jade is quite happy to take her place.
Now, why is your mother sending me chocolates?
She's done your dinner as well. She gives great stories, and she's just such a lovely woman. I've adopted her as my nan now.
Just having someone you know comes, if it's only once a week, twice a week, it's company, you know?
She's now part of our family. She's called extended family now.
I call her my guardian angel.
You can sit and listen, that's all it takes. And everyone's got 2 ears, so everyone's capable of listening, so anyone can do it.
So I'm glad that worked. We need medical care, we need social care, we need all the systems, of course we do. But I was talking to a medic in a town I shan't name last week who said, oh yeah, WRVS, you do a lot of talking. And it's true. But actually sometimes a bit of talking and a bit of support actually works for people and sits alongside that. So my plea would be, as we're thinking about the integration of these two systems and the opportunities that lie ahead, please let's think about how we use the third sector and people to knit the whole system together and actually make everybody's outcomes better. So, thank you.